Hello, and thank you for joining today's virtual educational program, Mind with Cancer Support Community Los Angeles. I am Edwin Rodarte, and I am the Virtual Program Associate at CSCLA. I welcome you to this week's webinar titled Your Life, Your Choice, Discussing End-of-Life Choices. This webinar will include end-of-life choices and how to have these important discussions with doctors and family members. You will learn how to advocate for yourself or others and ensure you get what you want at end of life. And we'll also discuss the difference between palliative care and hospice care, how to choose the right hospice for you or a loved one, and which documents you should have. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Without further ado, I'd like to welcome today's speaker. Karen Morin is a patient advocate and end-of-life counselor and a retired oncology and hospice nurse. Ms. Morin has been an active volunteer for Compassion and Choices since 2013, acting as a vocal medical advocate for medical aid in dying legislation in California. Ms. Morin started LA Patient Advocates, a concierge patient advocacy and end-of-life consulting practice that serves all of Los Angeles and Ventura County. Welcome, Karen. Thank you so much for joining us today.
That list, I feel like, oh, I'm not going to get to everything today. But as she said, I am a patient advocate and have worked with end-of-life choices. My background is oncology and hospice nursing. And for years, I worked at a cancer support center similar to LA Cancer Care Community. And I ran a metastatic support group. And very often, my patients would tell me that they wanted to talk about end-of-life choices. They wanted to talk about death and dying. But the two groups that didn't want to discuss it with them were their families and their doctors. And so I hope today to be able to give you some of the tools to help you get some of these discussions going. And as she said, if you have any questions, please let us know. And I'd like to be able to answer them as we're moving along. So, and this is one of the great books on our subject. If you haven't read it, I hope you will. And oh wait, we're going way too fast here. My little mouse is jumping along. Endings do matter, and we want you to be able to have the choice and the ending that you want and the way you want. And to do that, we look at some of the studies that we have about how we want to die. People want to be at home. They want to have their pain and managed. People are always asking, we always want to assure our family and loved ones that we are going to keep them comfortable and support them throughout, and have their values respected. And this is a big one in our society about whether they're going to be a burden, whether it's a financial, emotional, physical, whatever it is. People lose some of their quality of life and their ability to take care of themselves. It is something that is very, very upsetting, And most discussions about end-of-life preferences don't occur until 1 month before death, despite the fact that we know that most patients really desire this information earlier, both from their doctors and that discussion with family. So what is a good death? How do we define it? And of course, that's going to be unique to each of us. And it's influenced by not only age, gender, and race, but also our experience. Often we start some of these discussions because of what we've heard, Aunt Marge, or you've heard about a friend or a relative that died in the ICU, or we have experiences with, especially in this last few years, with COVID and what was happening in our hospitals because of COVID. But up until the mid 1940s, most individuals died at home. Care for the elderly and dying didn't shift to our hospitals and skilled nursing facilities really until 2008. And we found out that at end of life now, suffering is occurring more during the last week of life. There's a considerable reduction in ICU admissions and high-tech interventions, the more we can discuss what it is we want and don't want with our family. So it's never too early to get these discussions going, even those that have no illness at all. I'm talking to a couple of friends lately who have really started to put some of this paperwork together. And it really is it is an ongoing process. We put a lot of time and effort into planning births, weddings, and other life cycle events. So putting a little bit of time and discussion with our family about what it is we want and don't want is going to really pay off in the end. We know that the benefits really outweigh, the opposite of not having that discussion. And when people don't know what someone wants, a lot of times I'll have people come up to me and they'll give me this long narrative about what's going on with a loved one who's in an institution, and maybe they're on machines, or maybe they can't really take care of themselves. And in the end, it's like, well, what should I do? And then I'll say, well, have you talked to your mother? What is it that she wants? And there's this dead stare on their face, and you find out that we really haven't had that one-on-one conversation with what it is they truly want. And sometimes it's hard for a family member to say what they want. They don't want to disappoint. I can't tell you how often I was giving chemo to an elderly woman who said, or man, who said, I'm only doing this because my daughter or son wants me to. They didn't want to continue treatment. And so we really have to all work harder on forcing each other to get into some of these conversations. So we all know why it's important. So, and we know that people who have these discussions are going to have less aggressive care near death. We've talked about that. And the bereavement and the adjustment of the loved ones we left behind are going to be better because they know that they've talked to you and they have heard what it is you want. So as horrible as losing someone is, knowing that we've been able to give them what they want gives us much, much better grief to know that. So, and this goes not only for the discussions we have with our family, but the earlier you have these discussions with your doctor, the better. And I think I had something here about, why doctors don't want to have these discussions. Trying to find it in my notes, but often they have the feeling that they've let patients down, or that they have trouble prognosticating how long. We always ask doctors, how long is it going to be? And a lot of training earlier in the earlier years, doctors didn't get the training on talking about death and dying. Their role was to treat. We're going to treat. But getting those conversations was always harder. I can always remember in July when the new interns came in, and the first time they had to pronounce someone, it was like, oh, I didn't know. What am I supposed to do? So interesting enough, there was this recent article in the Journal of American Medical Association about what's wrong with advanced care planning. And, we put this huge emphasis on, do you have your advanced care documents? Do you have these documents done? And before you go into a hospital, there's always asking you about this. So there was a review of all of these documents and end-of-life decision-making, and finding out that sometimes, patients' perceptions and family perceptions were not always getting met. And some of these, all these plans we had put in place were falling apart. And the reason often was that it's one thing to have papers put down and ideas put down on paper, but if the doctors didn't get it and the person who is your advanced care directive didn't have it. So what it really comes down to is whatever documentation you make, it's really the people that are going to make the decisions. It's the family members or those who are your healthcare directives who are going to make those decisions. And some, as you saw during COVID, we get these phone calls or people are on FaceTime. We're getting better now. Family members can be in the hospital and can be making those decisions. But when it comes down to is the more conversations you have and the more people have a real understanding, those around you have an understanding about what it is you want, then we're going to have much, much better outcomes. And so I'm not going to go way into all the paperwork. I do other talks where I do half of it. This is how we fill out the paperwork. This is what everything means. But I want you to have an understanding of what the documents are, how they are used, and then let's get into some of the end of life choices that we're really trying to make here. Okay. So basically, when we're talking about this preparation and these discussions, language matters, of course. Don't talk vague things. It's more about what it is you want and what quantifies that quality of life for you. There are people who want to do everything and they want to do everything up until the very, very end. And there are other people who are very specific, like, no, I don't want chemo, or I don't want surgery, or I, don't want a lot of heroic methods. And we're going to talk about what those methods are. But the reality is you can draw the line anywhere you want it, and you can change it at any time. We have to look at advanced directives as an ongoing process. It's not going to be one and done. This is going to be something that I'm going to want you to go back to every now and again. Okay. So what is it? When we talk about advanced directives, we're talking about a document that's going to say, hey, look, if I can't talk, remember, this is just in case you're not able to speak for what you want, okay? And a lot of people go, well, even if I'm sick, I'm going to be able to speak up for what I want. So it's really that incapacitated version that we want to set up so that those around you know that this is what she would want. But it's not a group. It's going to be one person that will speak as your healthcare agent. Oh, I'm sorry, this mouse is just getting, is very crazy, but it's also trying to tell me that we're going to go through these a little quicker. So we're going to name a healthcare agent that's going to make a decision. Often we'll say more than one. But when we think about those decisions, I want you to think a little bit about, now this is my slide about look, I was just at a conference recently and they had a t-shirt, which I bought, that says, people don't die as you see on TV. Not only do people not die as we see on TV, but what you see in terms of CPR and people getting intubated, and in the end of 20 minutes, the tube comes out and they're talking and looking all rosy. So the reality is that people don't have those exact same, our numbers, I have the updated numbers since COVID here too, about is not as effective as we see on TV. The reality was 18%, and that was before COVID. So in general, only about 1/5 of people survive in hospital cardiac arrest. And the numbers for patients with COVID-19 were even worse. Those who received CPR during COVID were 3% of people older than 18 lived through it. So before the pandemic, it was 61%. So we really want to think about what this CPR really does for us and what the chances of getting it out of the hospital if we do have CPR. And so who is this person who is going to be making decisions for you? Very often it's our spouse or family member. But think about that sometimes. We want that person who is going to stand up for you, who is going to advocate for you. And maybe if they're about to make decisions that they know that you really wouldn't go along with, you want someone who's not going to be afraid to speak up and say, no, despite everything that you may think, this is what I know Aunt Susan wants at this point. So do they have to live nearby? It helps if someone's nearby and they can be there. Today, the one thing that came out of COVID is that we are doing so much more with telemedicine and FaceTime in so many ways. So we can do a lot. The doctors and nurses are a lot better about communicating. But think about that. You can name who you want to be your agent. And I always say have a backup. And you can also name who you don't want. So, but take charge of this and think of it as something that's going to be ongoing. As you and your health conditions change, so shall your plans. You're going to get older, things change, and it's going to promote a few changes. Acknowledge what your thoughts are and how they may be changing, and address some of the important things that you might want to worry about. We also have some addendums that I'm going to give you. So I'm going to give a lot of resources, web pages, and links that are really great help. Compassionate Choices is a group that I've worked with for a long time. It's a nonprofit group that works towards advocating for end-of-life options, all end-of-life options for all kinds of patients throughout the country. They've helped to sponsor a number of laws and getting them passed, but they have I'm going to give you the links at the end of their great website with a lot of resources that you can download, as well as advanced directives and Pulse and some other things. So I know there's a lot of slides with a lot of information, but we're going to give you all those links at the end also. Oh, this was the slide I talked about earlier about why, I don't know how it got here, but why some of the doctors can be so bad sometimes about just not saying what has to be said and when it has to be said. And different doctors and different specialties have different issues on this, but it's getting a little bit better, but definitely. So recognize that it may take a couple of conversations, and know if you have Medicare now, Medicare covers end-of-life discussion. So when you make your appointment, let's say that you want to discuss this, you want to discuss your end-of-life plans and talk about what you have in mind, and make sure that the doctor is a partner in this. Make sure that you and he or she have the same values, and they're listening to you as far as what you want, and that they're going to respond to those choices of yours as you go along. Let them know what you want in terms of information and where you're headed on this journey. And ask them to document your wishes in the chart. Should you and they not agree later on, having that documentation in your chart is very important. Let them know about your life, your values and milestones that might be coming up. And based on where you are in your treatment, what if you do nothing? Or what is this treatment giving you? Oftentimes we hear the words treatment, and for a lot of people, treatment means different things. Doctors are trained to treat, but what are we treating and what are we getting from that? Treatment is not a cure, and those of you with cancer know about different levels of treatment and remission. But when we talk about advanced directives and we get our family talking about these things, remember, each of us need to have these plans. When we go back in the history of advanced directives, it really was younger people who had been in car accidents, or we had a mixture of alcohol and pills, and now they were in a coma, and gee, what do we want to do? We never really talked about this. So we're all dealing with our parents. So it's not just the cancer community that needs to be working on really accessing and having a good end of life plan. I really like it to be all of us, okay? So those priorities and what your quality of life, what you're willing to put up with and not putting up with, what's important. Some people want to be able to get to the Dodger game. Some people want to be able to watch it. What are your fears and worries? I know this is a lot, but sometimes it's just a way to get started. And sometimes you can use the news, use what's happening with other friends and family. Talk about what's happened with them and what you get started with a conversation about what your family would be willing to accept and how they would deal with different things. Okay. This is a great book, but about someone who faced an illness at a very early life. And what he says is so true. Your values are constantly changing. You try to figure out what matters to you, and then you keep figuring it out. Death is a one-time event, but living with terminal illness is a process. And very much, with cancer care now, it's not, it is something more in terms of very chronic illnesses that go on. And what we thought in the beginning may be something very different later on. So talk about the goals of treatment, expected response, and quality of life comes up again and again. Make sure you have someone who is really willing to discuss all the available options. Sometimes we get get into a narrow tunnel of there's only one way of doing things. And so there is more than one way, and you can have those discussions. I also talk a lot about make a video, especially for older people. We're going to talk a little bit in a minute about dementia. And sometimes if you have certain wishes and you want to make sure that they're going to get followed, you have family in another part of the country, by making a video and said, look, this is really how I feel about this. This is exactly what I want. I think this helps family members to really understand that, oh yeah, I can see that she's, mentally competent. This is really, she has some passion about this, and this is how she feels. So make that video, put it on a little USB, and if you share it or give it, and make sure not only your healthcare advocate has it, but maybe you want a family member who might question things to have it, okay? And then after you do all this, how are you going to make sure that these wishes are followed? Again, I'm back to that multiple conversation, but come back to it. and make sure you have someone that you can trust and who will advocate for you. Go back to it. It's all right to change it. And make sure, like each year on your birthday, make sure that you're signing it again, put a date on it, say, I've read this and I still wholeheartedly agree with this plan. You can indicate who you don't want, but make sure you've checked it. You know, the addresses, phone numbers change. Make sure you've given copies. Now, just having it and having it filled out, I've talked to people and go, well, you know, I have it. Yeah, that attorney who filled it all out has it. Okay, make sure you get a copy to your physicians, and often you'll have hospitals ask for it. There's also a number of services now that will upload. I think I have the links at the end, but you can also upload them. You can put them on your phone. There's a lot of tech things we can do now to really have these available. And we're going to talk quickly about the do not resuscitate and the pulse in just a minute. But the ongoing, the benefits, of course, are your wishes are honored. There's less confusion and family conflict. And it really is a gift of love to know when things are really happening, it comes down to that point. Your family knows that this is what you want and they're giving you what they want. There is a lot of peace that goes to that. And it really involves a lot of your safety too. You're not gonna have to worry about going through so many unwanted procedures when your wishes have been spelled out right up front. So the pulse, I often speak about because it's a physician's order for life-sustaining treatment. It's a pink document. So you have your advance directive that's written down, but the pulse is for someone who has an underlying chronic illness or maybe a life expectancy of the next year, or we wouldn't be surprised if they died in 6 months or so. Or if you are really at a point where you don't want anything else. This is the one document that EMTs, oh, we went the wrong way there, that EMTs will honor. Okay, so it comes, I've shown it to you because I want you to know a little bit about what it looks like and what it's really asking, okay? It's meant to be filled out together with your physician, but it's really good to take a look and understand what options are there. And it's signed by your physician. So if EMTs were called to your home, this is the one document they'll look at and they will honor. And also, if you were taken to the ER, most often, this is the document that physicians in the ER will also honor. Sometimes not, and I've had a lot of people say, oh, we did everything you said, and then we got to the ER and they didn't pay any attention. And you know, we have a little bit of that with some of our religious hospitals, but this is your best bet to try. And have this. So it applies an emergency. And it's really saying, do you want CPR and resuscitation or not? You can allow a natural death. If you're not in full cardiopulmonary arrest, then there are other interventions. Comfort measures or limited additional interventions such as IVs, fluids, but you don't want intensive care. And it also has a checkbox for do not transfer at all or full treatment. You want everything. And then there's an area about nutrition, whether it's artificial by tube or a trial. So, and you can also put your own notes on this too. You know, you can work with your doctor on this, but it is good. I think it's good for a year now, and it can be copied and should always stay with the patient. But, oh, yeah, that that was basically it. That's we have it, other states call it I think in New York, it's the most, they're trying to get it in most states, but it's, so it's advanced care planning, the advanced directive, and that pulse for the last little bit to really make sure that your wishes are followed. A lot of times patients are also around hospice at that point, but sometimes they're not. So and that was a quick thing on advanced directives. I can do a whole bit, and if you're stymied or stuck and want some help with getting an advanced directive plan together, I'm happy to help. And I also do that on Zoom individually if there are cancer care community clients who want help with that. But I also wanted to talk about these end-of-life options that we're really working towards and wanting to say this is what we want and don't want. So what are the end-of-life options that are available to us here in California? So the first is pursuing all treatment, of course. We all have the right to pursue all and every medical treatment that's available to us. But we can also discontinue or decline medical treatment at any time. And when I speak of that, I'm speaking in terms of, I have adult patients who stop, that are stopping dialysis at some point. They've been on so long, they're not, I'm not going to get a kidney, I'm really done. Cardiac patients who have been on treatments for a long time and say, look, I just want to stop at this point. So we always have that autonomy and a voice to really stop treatment anytime. Now, remember, when we're stopping treatment, it doesn't mean that we're stopping to care for a patient. There is always care available. And lately, you've been hearing a lot about palliative care and what is palliative care? Boy, these are, sorry, they're really a little bit, my slides are out of order here. Let's see, no, where is the palliative care slide? Sorry, let's see if it's. One more, I'm going to try one more up here, and if not, we're just explain it. Okay, so palliative care is really symptom management. Okay, we've really realized that there are a lot of patients now that have a lot of chronic illnesses, have a number of different things going on. Patients are living longer and living with multiple diseases. You'll see these checklists of all the different problems. And each of our doctors are working on one or the other. The oncologist is treating this, and the orthopod is treating this. And then often we have patients that are having a lot of pain. So it's not just pain management. What a palliative care team will do is they'll manage all the symptoms you might have. It's sort of like what primary care doctors were doing, but it's in a palliative care situation where we're going to make sure that all your symptoms are managed and you're going to continue to get care from this team. You might not, we're not focused on curing whatever it is that is going on. And that is really a step before hospice. And often people are thinking about hospice, like when I talk to you about, well, you might be ready for hospice. Oh, no. My mother's not dying now. And a patient doesn't have to be actively dying to go on hospice. I had patients on hospice, a year or more. Often it's patients who have said, I don't want to treat anymore. I know I'm not going to get better, get cured of this disease. I just don't want to do anything. Well, not doing anything doesn't mean that we can't care for them. We can't make sure their symptoms are managed. And when someone is on hospice care, and you'll find a lot of the hospices in here in LA are also talking about palliative care at the same time. Sometimes they can work the same way, or it can go from palliative to hospice. But for a hospice, palliative, anybody can be on a palliative care for years and years and years. Hospice care we have to certify that the patient has 6 months or less to live. Now, nobody can be sure of any of those things. And very often, these patients that have been on a year or more, at the end of 6 months, if the patient has declined, lost weight, all of a sudden they're not able to get around like they used to, their symptoms have grown, then we can increase it to another 6 months. So not all patients are actively dying, but they're not in curative phase, okay? And not all hospices are the same. We've all seen the news here in LA. There's a lot of small, wonderful hospices, but they're not all the same, and they don't always offer all the same services. But while you're on hospice, all the equipment that you need is furnished by the hospice. It's paid through the insurance or Medicare. All the medications for comfort and symptom management. So within your comfort care, those medications are delivered and come to the home. Social workers, spiritual advisors, weekly RN, sorry, how do we do that? Weekly RN visits and aids, whatever you would need in terms of activities of daily living. Respite care is if a patient is very, very ill and have needed around the clock, and maybe the family has become overwhelmed with it. Respite care would be they would maybe go to a facility for a few days so the family gets respite. That's what the respite care is. Most patients request referral. This point has to do with it. Oftentimes, I find that patients are asking me for hospice care, or they come, or they've asked their doctor, and their doctor said, not yet, not yet. And so it can be, you always have the right to say, look, we're ready. We know we want to go on hospice, and you can change at any time. You can, if you're not happy with the hospice that you're in, you can change and go to a different hospice. So talk about your needs. What is it that you have already envisioned as your plan of care? One of the great things I've found about hospice lately is if I have a patient that comes to me and they're in a great deal of pain or discomfort, and we call up the hospice team or the palliative care team often, we can get hospice out there the same day, get them evaluated and get them admitted and get pain management under control right away and get all their symptoms managed. We want to find out if they participate in medical aid and dying. We'll talk about that in a few minutes, and some of the other end-of-life options that are available. But we ask about their medical directors. Would you be able to continue using your own doctor, or would you use the hospice's medical director? Mostly the hospices in LA work with their own medical directors. Some doctors will then be involved, and but it's usually a combination, and often doctors are saying, look, hospice doctors knew a little bit more about comfort meds and end-of-life meds, and you want to be working with them. But I find that your primary care doctor can stay involved as much as they want. VSED, we'll talk about in a second, is voluntary stopping of eating and drinking. But the important thing is pain management. I really, really want to emphasize how important that is. And I know that a lot of people with the opioid crisis, we hear a lot of people talk at the end of life like, oh, I don't want them to get addicted. You don't get addicted at end of life. especially if you're having pain. So everyone's pain needs to be well managed, and want to make sure that they have access to great pain specialists. I find most hospice directors are that. If not, be working with a palliative care or a pain management doctor. And, talk about your pain in a very straightforward way. People get very concerned about quality of life and being able to focus and talk to family members, and know that we expect that in hospice. Often it may take a little bit to get used to the pain management, and there's different ways that we can work with pain medication, and sometimes you get used to it, sometimes we can change it and add other medications to make sure that you get the quality of life that you want. But you should always have your pain managed at the same time. So that's the biggest priority, is managing your pain, and make sure that your caregivers know. And I'm sure you know that it's a round the clock kind of thing. We want to make sure that you're getting pain management before pain gets very high. So when it's just beginning, get that pain medicine into you before it gets really, really bad. And a lot of times we can work with around the clock pain medication. Be specific. But once you have it, use it, especially at end of life. And I just making the point so that we really encourage those of us around us at end of life to use the pain management that's right for them. So end of life, voluntary stopping of eating and drinking. Often I'll get patients who have said, look, I'm done, or Parkinson's. Sometimes patients that don't qualify for other end-of-life options. And sometimes they'll say, well, is there any other choice? Do I have any other way that I can speed things up or get some control of what is happening now? Voluntary stopping of eating and drinking is one way that it's a peaceful way to control the dying process. It's legal in all states. We really recommend it's done under medical supervision with hospice or a palliative care team. It takes 3 to 6 days to go to a coma once you've stopped eating and drinking. 6 to 14 days average. It really produces a number of endorphins in the body, which act as a natural anesthetic. But we want to make sure that we're including pain and symptom management. We can control some of the secretions. We can work with people through the hunger and thirst with the first few days. But everyone has the right to refuse food and fluids. But family of those in a care facility may need to work closely with the staff to ensure that their choices are honored. So, yeah, often early stage dementia patients will choose this option. These are just some of the stages and what we usually see in VSED. But had a few patients, mostly, I guess the patients I work with mostly have been Parkinson's patients also too. Palliative sedation, I mentioned because it's really, we have seen it a little more lately, and I think it has more to do with medical aid and dying in California than anything else. But palliative sedation we see often in patients who have a high degree of pain that is not well managed, whether it's because of the pain itself and where it is, or you have patients often who have who don't have oh, I'm sorry, what am I going to say? Allergies to pain medication. Some people, the receptors just don't work that well. And we can see patients with on highs amount of medications that really aren't being effective. Bone metastases is an area we've seen a great deal. So it's comfort care, it's non-curative care and symptom management. It can be done in conjunction with curative or palliative sedation. Often induces a coma when pain and other symptoms, these slides, aren't working. So we can get someone into a coma and they may pass away after that, or they may just find that their pain is managed that way and the patient is comfortable and peaceful. And with that, the family is much happier too. This is only under medical care. A doctor has to initiate that. And these are always patients that are in the hospital. It's not something we usually do at home at all. And so lastly, we'll discuss the California Medical Aid in Dying, or the End of Life Option Act. So this is an option that we have in California since 2015. It's a medical practice of a terminally ill, mentally capable person with a prognosis of 6 months or less. Okay, you have the option to request from a physician, from your doctor or the hospice doctor, a prescription for medication that you can choose to self-ingest at any time to die peacefully. Okay, it's also an Oregon, they called it death with dignity. Governor Brown signed it in 2015. It started, our first date was June 9th, 2016, and we had an update this last January. But 1 in 5 Americans in the country now have access to one of these laws, where it's actually in 10 states now. Compassionate Choices, the group I was talking about, has been very active in helping to work on the legislation. So California, Colorado, Hawaii is the most recent. Montana, New Mexico, Oregon, Vermont, Washington, New Jersey, and Maine. DC has had it for a while. So it's been some legislation, some ballot initiative. Oh, this sort of talks about what and where. But we, mostly I hear people say, oh, well, they have it in Oregon. I wish we had it here. And it's like, oh yeah, we do. And it's one thing to have a law, but it's another thing for people to know about it, understand it, and to get doctors working with it and patients asking. So we've definitely seen more patients asking in the last year or so, and using the law more than we did in the beginning. So in January, it was a legislative Senate Bill 380 passed in the Assembly and the Senate, and we'd worked to make some changes in the law that were, Karen, this is just crazy, effective. And so we changed. There used to be a waiting period between the two laws, between the 2 physician visits that you had to have. The law we're going to talk about in a second requires 2 doctor visits and a consulting doctor. Before, it was 15 days between those doctor visits, and that's, for those of you who've been sick, it's 2 weeks is crazy. And if you're going to different doctors and waiting, and we really had a great number of patients who died during the waiting period. So the waiting period is now 48 hours, and it was quite something to get that passed through the legislature. New Mexico, which just passed a law, started with 48 hours, and Oregon, which most of the laws have been fashioned after, had changed their law to, if a doctor felt that someone was not going to make it or had less than 3 days to live, he could change it that way. So the final attestation was just something you had to sign at the end that said that, you know, you still wanted to do it. And transparency in the sense that we had a lot of hospices that were out and out lying, or would, you know, patients would ask about it and say, well, nobody here and doesn't do that, or you have to go to an ethics committee, or it was just a lot of misinformation. And now hospices have to have on their website whether they support the law or not. And if you request the medication or the law to a physician and they don't do it, they have to document your wishes and refer patients out. Well, you know, that's the law. Now we're getting to see if that actually happens. So, and just like in the abortion laws that we're seeing, there are a number of lawsuits out there about, you know, changing this. And oh, I have the craziest mouse today, and if I do it with my keypad, it won't work. There we go. So there have been some limitations to that. So yes, but so right now, as it stands today in January, if you're 18 or over, with 6 months or less, and you're mentally capable of making decisions, you can request the medication, and of course, anybody can get a medication and decide not to take it. That happens about a third of the time. So these are just a few facts. There was a lot of research in the beginning of the law, especially in Oregon. There was a lot of, you know, misinformation about what the law was and wasn't. So you can't coerce anyone. You know, you have to be able, these 2 and 3 doctor visits that we have with patients, the physicians, well, we'll go through a little bit what they ask and how they confirm, but there is, with over 20 years in Oregon, there's never been a case of coercion or anything else about, you know, most often I find, especially with elderly patients, they're like, you know, people aren't ready to say goodbye yet. So it's often takes a little bit of time for the family to come around to, okay, there's a definitive date here. We're all gonna say goodbye, but we all get to be here and we all get to say goodbye. So, and then there was like, well, the insurance companies, you know, they don't want to pay for treatment, so they'll pay for the medication. Well, there's been no research or anything that's come up to prove that that is the point. We do have some institutions that are very good about referring patients who want to use medical aid in dying. But in terms of curative treatments, you know, there's no insurance company that's saying, you know, to approve curative treatments. So let's talk about what the safeguards are. You know, the physician must inform the patient that there's all kinds of other end of life options, you know, just like we've seen today. There are other choices you can make. What are they? We make one verbal request, the patient fills out a form, and a doctor, and again, that COVID telemedicine, we're using that a lot more. Sometimes the doctor will go the first time. Sometimes we'll do them both over telemedicine, and the doctor gets a history and physical and has talked to the patient about their hospice journey, how they got there, what they want. Another physician is confirming the eligibility. So sometimes it's the primary care doctor, sometimes another hospice, maybe the oncologist. So we have 2 doctors that are saying this patient is terminal. They do qualify for their medication and they're mentally competent. And when the patient fills out the form and signs it, only one of those witnesses can be a family member. Another has to be someone outside of the family. We have to also know that the patient can take the medication by themselves. And I'll talk about that a little bit in 1 second. Well, the medication it comes as a powder, and we add some liquid to it. So it really comes down to about 3 ounces of liquid that the patient needs to drink it in 2 or 3 minutes. And then the patient goes into a deep sleep, close to a coma, within about 10 minutes. So when we say they have to self-ingest, we can help mix it up. We can put it in a glass, but they take it and drink it on their own. We can also use feeding tubes if they have a feeding tube, but they have to push the plunger or turn on the gravity-fed tubing. And in some cases, if it's a patient, got that worse fingers here with these slides today. If there's a lot of nausea and vomiting, there are other ways. We can do it also rectally if possible, if we need to. Wills or contracts insurance are not affected. You know, it says so specifically in the law that this is part of the dying process, and insurance is not affected either. When we say age or disability is not a factor, you can't qualify because you're 101 and I want this, I want to go now. Or if you have a disability, actually there is a lawsuit now in the California courts because there are a number of disability rights folks that are saying this fact that we have to self-administer leaves out a number of neurodegenerative diseases, ALS patients, people who maybe want to take it, or the ALS patient may take it earlier than they might want to have their death, because then they can drink it or they can use their hands. So it's really, there's a lawsuit about the disability feeling like they have been locked out of this law when they don't want to be. So it'll be interesting to see what happens with that. The death certificate states the underlying disease, whether it's heart disease or end-stage renal disease or cancer, whatever it is, that's it. Nothing is mentioned on the death certificate about medical aid in dying. So I've had patients who've had family members around, and some patients who may do it in the evening and not tell anybody at all. It is not considered suicide or euthanasia. Suicide is a violent act. It is something that it can be usually someone who is mentally unstable. And medical aid in dying are patients who are actively dying and who desperately would want to live. So even the Association of Suicidology says it's not suicide. That's why we use the terms end of life option or medical aid in dying. So, this is the update on the referring. So a doctor or a hospital can opt out, but they have to put it on their website. I'm telling you, there are a few hospices I know of that have always used medical aid in dying, and you'll see it right away on their website that they do. The ones that don't, they actually have it on their website. You're hard pressed to find where they have hidden what they that they don't have a policy and they don't support it. But there are a number now where even if you are on a hospice and they don't support it, we can now facilitate that. We can stay in the same hospice and we can still make sure that you get medical aid and dying if you want it. There are many ways to do that now. So there are a number of doctors that we can use separately and outside to go in and make sure that you get the end of life option that you want. So how does it work in practice? There's a medication that you take about an hour before, some Zofran and Reglan, and most of you are familiar with those medications, and that helps to prevent nausea and keeps the medication down. It used to be Seconal at the very beginning of medical aid and dying, but then the cost went up and up. It was like, went from $300 to $2,000, and then the makers of Seconal just stopped. And so for a while, there was a couple of different combinations of drugs that were used, and there's a association of medical aid and dying doctors who have worked on this combination, but it's pretty much meant to work at stopping the heart and the breathing at the same time. I have a lot of patients who people will say, well, why can't we just, take what we have and all, or take the meds? And the point is that using medical aid and dying, we know that this combination of medication is going to work. It always works. It works peacefully, and it works, and it's legal, and that's the best way to go. I know too many patients who have tried, medications that were there that then they wake up or they vomit, or this is the best way to indeed do it. So it's 65% of the patients in Oregon took the medication. So a lot of patients having the medication and knowing it's there was enough to give them a comfort and know that, look, I have another way. If things get unbearable, here is a way. But that's the job of hospice, is to make sure that everybody is comfortable and peaceful. We like to have people enrolled in hospice and make sure that they get the support that they need throughout this process, and the family gets it. And we know that just having the law on the books has enabled a much more open conversation. More people are talking about end-of-life options. More people are getting palliative care earlier and getting hospice earlier. And so whether it's not so much whether more people are using medical aid and dying, it's the fact that I think more people are beginning to talk about options and make sure that people aren't getting as many trips to the hospital or getting these unwanted, aggressive treatments at end of life that nobody really wanted. I'm just going to go quickly through some of these slides because I want to talk about dementia. This is really every year in California, all the data goes back and we get a report. And we have found that more people have been asking for prescriptions. As you can imagine, the people that are accessing it are people that know about it, people that can hear talks like this. So there is a big drive right now to get more people of color and Latino, get it out in the community so everybody knows about it and is able to access whatever end-of-life choice that they want. So you see the numbers are going up a little bit, and just talks about percentage who actually used it and the mean age. And a lot of times it was the higher percentage being cancer patients, and cardiac patients are the most that I've seen lately. Going back to our forms here. So we want to remember to go back and look at the 5 Ds: decades, death, a divorce, a diagnosis, or a change. So people will say, look, we've talked about all these things, and then what about dementia then? Because I'm going to make all these plans, or maybe I want medical aid in dying, but then what if I get dementia? So, one thing I wanted to mention too is addendums. We can do these advanced directives. We can also add addendums. And this is just an example of a COVID-19 addendum about if I were to get COVID-19, what would I want? Would I want to go to the hospital, want to stay home? Now that there's vaccines and change in a lot of the COVID care, they're not as important as they used to be. But as I go in a little bit to dementia, talking about, okay, these are all of our steps and advanced directives, the pulse, and updated. But as we talk quickly about dementia, it's the same idea that think about dementia early stage and late stage, and Compassionate Choices has some amazing website links on how you can look at dementia and what you want at different levels. And I really recommend it, going through it, and then put those wishes of yours about dementia with your advanced care directives. So having a discussion is supposed to have a positive effect on your relationship with your doctor. Yeah. But having these addendums on, so if I get dementia, what do I want? So what is it? Alzheimer's and dementia, degenerative brain disease. It's a specific, and it's an overall term that covers a group of symptoms. 1 in 2 older adults now die from dementia, and many people live as long as 10 years. We used to be that 60% of Americans end up in a nursing home or a skilled nursing facility. But, for years, we had people who had dementia, they got pneumonia, and the pneumonia took them. Well, now people are living longer because oftentimes they end up in institutions and not at home with our loved ones. So if you don't make decisions early on about what you want or don't want, then your lifespan is going to get increased too. So this is what it looks like on the website, but there's a values and priorities tool. There's a dementia decoder, and actually will take you through different timelines of if you were to get dementia, is it the beginning? Do you have any symptoms? Do you not? I wanted to just sort of walk you through it a little bit, because, and even if you don't do the dementia walkthrough, you get an idea of some of the things you could put on your advanced directive or fill out about dementia. But the question is, no, you couldn't use medical aid in dying if you had dementia, because you have to have your mental capabilities at all times. Even if you filled it out before, nobody could give it to you. So that's why we've had a number of dementia patients early on who used other methods, whether they used VSED or other ways to hasten their death earlier on. So we want to look at mild, moderate, or severe, and then you just sort of go through this and check off what you would want at different stages. Like I've told my family, if I'm not eating and I don't recognize anyone, that's the point where I don't want antibiotics. I don't want to be treated. Give me, keep me comfortable. Do everything that would keep me comfortable. So you can specify your wishes around food, fluids, infections, and antibiotics. And I think, frankly, in some of the ways around dementia are some of the areas where we need to be a little more upfront and specific with our family members about what we want and don't want, because this is where it can be harder. Dementia, people die with dementia and Alzheimer's every day, but we don't always think of it as the disease it is. And so if you were to say the same thing about your cancer or stroke, your family would, oh, well, they're right there with you. But so I think it's very important to write a statement about what you really want and don't want at different stages of dementia, and you can do that. So this, hi.
I'm so sorry. I don't want to cut you off, but we're a little bit over 1 o'clock, and I just want to have time for a few minutes, if that's okay.
This is, I'm going to just show you what the website looks like, and then these are the links I'm going to send you. Are there any other questions that I didn't get to or answer? I know we didn't have. These are just what the web pages look like that I'm going to send you to. That, and these are the links for the forms that we talked about. Okay.
Perfect. Yeah, so for those of you who are still with us, Karen is going to send over a one-page sheet or so of all the resources that she spoke about today. So if you are interested, you are more than welcome to go ahead and email us at info@cancersupportla.org, and we will go ahead and email you that. Also, I did enter in Karen's contact information because again, we won't have enough time for all the questions, but it is at the chat. It's Karen@lapatientadvocate.com. So you can go ahead and find her there as well. Karen, we do have one question, and it says, if a person decides to medically end his or her life after qualifying, of course, is it considered a natural death for life insurance purposes?
Yes, exactly. That's what I said about wills and insurances. So yes, the death certificate says the underlying disease. So it is a natural death and doesn't affect anything, whether it's a will or life insurance or anything else. It is natural. Yep. And it's up to you and your family whether you tell anyone or who. And even on the form it says, I've told my family and included my family, or my family doesn't know, or I don't have any family. So that's totally up to you. I've had patients who did it in the evening that were on hospice, and the family thought, oh, they passed away on hospice, and others who had family all around them. So it's totally up to you. But yes, it is natural.
Well, thank you so much, Karen. I know that this is a tough topic to talk about, but definitely a great resource to have on our website and for you to share with us all the knowledge that you have. I'm sorry we didn't get to too many questions today, everybody, but thank you so much. I honestly just didn't want to cut you off because I know that this is such vital information for people to have.
Now you understand why sometimes we do a couple of days, but please, I like to focus on both the paperwork and the end of life option. Please email me with any questions, and I always extend time to cancer care community patients. So anything, anytime. Okay.
Alrighty, thank you. And thank you everyone for joining us. Just a reminder, this is being recorded and this will be up in our video library in a few weeks. Thank you.
Thanks a lot. Bye-bye.